Hello and warm greetings from Jena to Cologne. Unfortunately, I'm this year only via Zoom part of this interesting conference. The topic of my talk is the role of LEMG in clinical decision making, and being part of the facial nerve center, I will extend this topic a little bit from the larynx also to the face. I think the basics is pretty much the same, and as ENTs we can use it on both fields. So if you haven't thought about using EMG for clinical decision making, think about it, not only for the larynx but also for the face. These are my financial disclosures. Part of this research I'm presenting here is sponsored by Matt L., who is, due to the pacemaking study, very interested in good clinical evaluation of the larynx. I have also some sponsoring from Jena University Hospital, but also from the Zentrum für seltene Krankheiten. So the most important question here is laryngeal electromyography. What for? It's hassle, it's money, it's time. So why should you do it? And how good is the evidence for its outcome and its impact on clinical decision making? There's a very interesting meta-analysis from 2011 from the Sulika group, asking exactly this question: what is the prognostic value of putting needles into a larynx, putting needles most cases twice, and it's an impressive data they show you. It's over 500 cases. You see it down here, 503 in total patients included in the study, and very interesting, especially here, nearly 200 are coming from Masha Grozheva, so from Cologne. So as reporting this here is not only interesting for the future, but it's also looking back that great work was done about the value of laryngeal EMG, published in 2008 from Masha et al. In Cologne. So here in Cologne they did all the follow-ups 2 weeks after the trauma. That's perfect time point, I will tell you later, and then a follow-up around 6 months, similar to most other studies. The criteria for good prognosis or bad prognosis were a little bit different in the studies, but it was possible to sum them up. So for meta-analysis it was partly comparable. Mostly for poor prognosis, it's no volunteer activity and pathologic spontaneous activity. You have to be very careful. Volunteer activity is something from brain going through the nerve, going to the larynx. That's something good. And pathologic spontaneous activity, FIPS, positive sharp waves, these are all things coming directly from muscles who are denervated, and this is very bad. This is telling you some nerves have been completely destroyed and the nerve is not supporting the muscles any longer with action potentials, so it's starting to create its own patterns. More to this later. These are the criteria, similar but not the same in all studies. Anyway, good enough for a good meta-analysis. So if you sum everything up, you can make a decision about a poor prognosis from up to 90% predictive value. So if you put the needle into the larynx, the patient has no volunteer activity. You ask him for, say, no activity, silence, and perhaps pathologic spontaneous activity, some tuck, 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 tuck patterns. I will show you more later. This is telling you, oh my God, this patient has really a poor prognosis, and this prognosis is right in 90%. So that's really something hard, something you can build up your decision making. What's the other way around? What about the patients with good prognosis from LEMG? Here it's only 55%, so that's just like flipping a coin. So if the patient has some volunteer activity, has no pathologic spontaneous activity, don't overestimate the EMG. It could be also only good luck. So by flipping a coin, you get the same result. So you don't know if someone recovers, if there's no movement and the EMG looks good. But if there's no movement by scoping and in the EMG, you see these bad signs, then it's very hard evidence that there will be a very poor recovery, and you can perhaps go forward faster to a definite solution. This was only about looking backwards. Now there was a prospective study from Clark Rosen, published from John Ingle in 2014. Very great study. We should do something like this for most of our methods. I think it's not yet done in such good quality for scoping or ultrasound. So here the idea was really to test if the LEMG has an extra value. So the study protocol is shown here. Patient goes to the laryngologist, performs standard clinical evaluation. Then a pre-LEMG diagnosis and treatment records are written down and fixed. Then a blinded LEMG is performed and interpreted. The LEMG results are reviewed and considered by the patient's laryngologist, and then a post-LEMG diagnosis and treatment plan is recorded. And now the pre and post diagnosis and treatment plan are compared. So that's really a very structured way, and the blinded LEMG is something difficult for someone, but these make sure that the person putting the needles in is not biased by knowing already that there's movement or not. It's really very hard, very good study. And the results are promising. They show that there is an impact. From 50 patients included in this study, 13 moved direct to a permanent treatment based on being placed in poor prognosis with LEMG characteristics, and so faster injections of the larynx were done, observation times were cut down, medial arteriotomies were performed. So really, help for the patients faster. So the key results of the study are these two numbers. 10% of the cases, so 5 of 50, the diagnosis changed, unrecognized superior laryngeal nerve neuropathias were detected, and differentiation between joint fixation variants neuropathia was possible, and in 36% the treatment changed to the LEMG. This was these 18 cases I just showed you. So elimination observation time, direct permanent treatments, increased observation if there were good results, and you were like, okay, let's wait a little bit longer, and decreased observation at all. So really, it has an impact. But in this setting, in the voice unit of Clark Rosen in Pittsburgh. So they were very, very focused. They did a high quality LEMG, that everything streamlined. So in this setting, this was really outstanding. Sponsored by Med-El, I was in the lucky position to visit this hospital, and it was really impressive what they did. Unfortunately, the reality is a little bit more complicated. If you look around, LEMG is something, or EMG is something, 130-year-old LEMG, so larynx needles are even well known since 70 years, but in clinical routine, very little people do it. There's a lack of agreement of the methodology and validation. Anyway, we think LEMG could be useful. In 2012, we published this paper and proposed a guideline how to do a LEMG. So there's nothing new in this paper, but it's a good collection of how to put needles in, which angles, how to interpret them, what muscles are interesting, and how to document everything. Ten years later, Gerhard Förster published a follow-up with focus on the most difficult muscle, but perhaps most interesting, the posterior cricoarytenoid muscle, and how to do it, how to get the needle in this muscle, and how to interpret it. But writing things is important, doing things sometimes even more. So great that you are here for doing things, listening to talks, doing hands-on cadaver dissections, seeing surgeries. We had this similar idea in Jena from 2014 on. Andreas Müller and I were organizing a hands-on course to teach people more about neurolaryngology. And one important part is how to put needles in, but also how to fix the damage, laryngeal renovation, augmentations, pacemaker, all this are in our scope. But now back to a little bit more basic things. What's going on in the larynx? Why do we put needles in there? What kind of signals are we expecting? And what is going on the level of the axons and the muscles? So this is a very simple model of the larynx. So the larynx is broken down to two easy functions. Opening from the PCA, posterior cricoarytenoid muscle, and closing from the TA-LCA complex. So of course reality is much more complex, but for the beginning I think that's fine. So the lines, the green and blue, are the axons, only very limited. In reality there are much more, and the hexagons are the muscles. They are innervated by these nerves, bringing signals of opening and closing. So if you now ask the patient to say ah for phonation, so there should be a green activity, closing activity to bring the vocal fold to the midline. And here you see some activity in the EMG. If you put in the needle in the TA muscle, ask the patient to say ah, activation of the phonation ah, 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 and it always, if you phonate, you have also this nice activation in the EMG patterns. Same is possible as the other way around. For the PC activity, blue activity is evoked by perhaps sniffing. Sniffing is a nice maneuver, so sniffing 3 times, that's a not too much distortion of the larynx. So if the needle is in the PCA, you can do this very fine, it's very precise, and most patients can do this without too much training. And then you directly see activity in the PCA if the needle is in the right place and the renovation is, as if there is a normal innervation and not a renovation with some mistakes. So now something has happened. Small damage, neuropraxia, not a complete cut, only some pressure on the nerve, perhaps a punch, perhaps some various infection, perhaps during surgery a little bit too much pressure on the nerve. So there's still activity going through it, but much less, perhaps 1%, perhaps 10% of the activity, not enough for a good movement, so the vocal folds are more or less not moving on one side, so you have an impaired movement, and only the healthy side is moving, and now you want to know what is the outcome. Back to the two studies I've showed you in the beginning. You put a needle in, you ask the patient to say ah, and luckily there is a little bit activity going up and going down in the pause, going up again for the next R and going down. So that's great. This muscle is not working very well, but it's working a little bit. A little bit is much better in EMG than nothing. You can grade this volunteer activity by no activity at all, that's worse. A little bit single fiber patterns, or strong or mild or normal recruitment patterns. These recruitment patterns are often a little bit tricky to differentiate, but yeah, so between nothing and a little, EMG is pretty good and precise. Now something else has happened. Someone has really cutted the nerve, so all axons are killed, or a virus was so strong to do severe damage, or a trauma. Same, you scope the patient, you see movements only on one side and the other side is shaking a little bit, but you don't know, is it only airflow or cross activation from the other side pulling the muscles together. You don't know exactly by scoping, but you want to know to have a chance to give a prognosis. Again, we put a needle in, ask the patient to phonate, and nothing in the EMG. Complete silence. So that's really worse. That's really not good at all. No activity. This would be push the patient to the side of the bad recovery. But it can get even worse. If you look up here, it's early. It's before 14 days. So you see nothing in the early phase. If you wait and do another EMG, or perhaps your first EMG, more than 2 weeks after the denervation, you get some pathologic spontaneous activity. And then now it becomes interesting, because if the muscle is completely denervated, even if the patient is not cooperating, is not activating it, this muscle gets some rhythm from itself. So by chemical reactions, this muscle depolarates and gets some activity and is making an auto-pacing. Tuck, 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 tuck. So this is something very typical and very different to activity created by the brain. So if the brain is working, it's always a little bit stochastic, so it's a little bit chaos in it. If it's just by chemistry, just by this auto-pacing, this activity is very stable. Here you see pictures from pathologic spontaneous activity. After 10 days, after 14 days, they start and it's very rhythmic. Tonk, 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 tonk. You see it here. Or this something can also happen that it goes up and down, but anyway, precise and rhythmic. And now time goes by, and luckily peripheral nerves have a good chance of recovery. So there will be some fibers finding their way back. Not always. Nothing is always right in medicine, but in many cases. So there's a good chance that this peripheral nerve start to get some outgrowth. It's like cutting a branch from a tree. There will be new branches finding their way to the light, in this case finding their way to the muscles, but on the way they will find new paths. They will not go the same way. They will branch, they will go to different directions. Perhaps muscle fibers from the PCA will go to the TA or the other way around, or they will branch and double activate it, as you see here on the picture. What does this mean in EMG? You get double activation. If you put the needle into the TA, you get activation by phonation, but also by sniffing, and the other way around. If you put the needle in the PCA, you ask the patient to sniff, it sounds good. If you ask them to phonate, it sounds good again, but you say, that's the wrong activity. So there's synkinetic reinnervation, aberrant reinnervation, double innervation, so that's not good at all. Back to the interpretation guidelines. so you can put a needle in, you get some insertion activity, a little bit activity you see always if you touch a muscle with a needle. So now you know you're in a muscle. Then innervation patterns, how dense they are, nothing, a little, or a lot. That's as much you get is better for the patient if it's at the right moment. Then pathologic spontaneous activity, this dot 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 activity, you will train your ear. Later it's easier to hear it if you have done some EMGs than to listen than to see it on the screen. So listening is often more important because it's faster and has better judgment about the rhythm. And last but not least, the antagonistic and agonistic activity. So we recommend you to repeat everything 3 times so that you can compare it, and always not only ask for one activity but also for the antagonistic activity to compare them. And we also do this not only for the larynx, opening and closing. If I put a needle in the forehead, I not only ask the patient to move his forehead, but I also ask him to close the eye, to poke the lips, to smile, and then perhaps get some pathologic spontaneous activity or synkinetic reinnervation by nerve fibers outgrowth in the wrong direction. So it's the same here, than here, and it really helps to learn it on both fields. As an ENT, both is valuable for you, both will help you in clinical decision making. If you want to write it down, we try to condense all the things we've just taught you on a one-pager. You can download it on our website, lemg.org. I can also send it to you as a Word file if you want to keep it a little bit easier. You can also cut some things out. Anyway, the website lemg.org is perhaps useful to get started. There are some videos. They are not very well sorted, so you have to start and look around which is most important for you. But if you are too lazy to read the guidelines, the papers we already mentioned, you can try to watch the videos or come to one of our courses to learn it. So is any benefit? Have you learned anything by doing it? Yes, we have. So in the beginning, we were expecting that perhaps half of the larynges we would examine over time would be denervated, or perhaps even more. But when we were calculating how often by putting needles in you get some activity, we were seeing that in the beginning it's really a lot of denervated, little activity, no synkinetic activity, but then it goes up and up. And yeah, if you do a late EMG, it's more than 70% of the cricothyroid muscles, the PCA muscles, are synkinetic reinnervated, so 70 to 80%. And if you do it in the TA, also at least 50% are innervated and synkinetic reinnervated. So for the question if there's reinnervation, if the muscle is still there, or is the muscle completely gone because of long-term denervation, nearly always we find muscle, we can stimulate these muscles, we can check them by EMG, cause luckily from somewhere, from the healthy side, from reinnervation of the damaged nerve, or even from the different muscles like swallowing or straight muscles, these dying muscles cry for help and get some reinnervation. That's completely new. We didn't use it before doing the systematic analysis of the larynx. I just mentioned electrostimulation. So instead of putting needles in, you can also do electrostimulation of the muscles. And here you see Klaus Podocznik doing it. He goes down with a probe, a flexible catheter, and he goes behind the larynx and tries to stimulate the PCA through the esophagus. And now there's some opening activity, not too well to see. So looks for the hot spot, and if he is optimistic to have found something, he can insert some hooked wire electrodes, so the picture get a little bit easier, a little bit more open, because the hooked wires are very thin, and then you can have a nice view and stimulate it, and then you see here a nice opening and closing. So the PCA muscle in this patient is still working, so there seems to be some kind of innervation, some kind of muscle, and the joint is still working. So this patient would be a candidate for perhaps a larynx pacemaker to keep this muscle who can be stimulated by surface and by hooked wire, also long term or by an implant. So before saying goodbye, I want to invite you to our next course. It will be next year, 12th and 13th of November 2026 in Jena, together with Andreas Müller for the continuous legius and me. We haven't decided which guest speaker we are inviting, but I hope it will be again a very interesting course. But thanks for your time, and I hope you have a nice rest of the course. Goodbye to all of you. That's the team from Gera with Andreas Müller, who was presented yesterday, something here. That's our small team from the Facial Nerve Center in Jena. With also contact with Innsbruck, with Hamburg, with a CranioNet, who's tried to bring people together to do better treatment for patients with rare diseases. Thanks for your attention. Goodbye.